An abdominal aortic aneurysm is a localized and permanent dilation of the abdominal aorta in which the walls lose their natural alignment and the diameter exceeds 3 cm. This aneurysm is the most common of all arterial aneurysms and is mainly located below the renal arteries in the subrenal region. The real danger lies in its silent progression. As the diameter increases, the risk of rupture becomes critical, representing a life-threatening emergency. This condition mainly affects men between the ages of 60 and 80 and are often associated with atherosclerosis, a disease characterized by the hardening and narrowing of the arteries due to plaque deposits. It is important to distinguish an aneurysm from arteriomegaly, which is a diffuse dilation without alteration of the vessel wall alignment. It is often occur in the context of polyarterial disease, also affecting the coronary or carotid arteries. More rarely, they may have a hereditary origin related to conditions such as Marfan syndrome or may be secondary to infections or inflammatory diseases. Aneurysms appear in different forms: fusiform, characterized by a uniform spindle-shaped dilation, or saccular, which is a localized bulging in the shape of a pouch. They are also classified according to the wall structure. True aneurysms involve all 3 layers of the arterial wall, whereas pseudoaneurysms or false aneurysms result from a rupture of the wall that is contained by the surrounding tissues. The formation of an abdominal aortic aneurysm results from a structural weakness in the arterial wall. This area of reduced resistance is caused by the progressive destruction of elastic fibers in the middle layer of the arterial wall, known as the media. This alteration compromises the integrity of the wall and facilitates vessel dilation. The progression of the aneurysm varies considerably from one person to another. On average, the diameter of the aorta increases by 2.5 mm per year, but this growth can be faster or slower depending on the individual and the associated risk factors. A particularly concerning aspect of this condition is the risk of rupture. When the diameter exceeds 5 cm, this risk rises to 22% over a 2-year period, turning an often silent condition into a life-threatening emergency. The causes of abdominal aortic aneurysms are divided into several categories, each reflecting distinct pathological mechanism. Atheromatous aneurysms are the most common and are directly associated with cardiovascular risk factors such as hypertension, smoking, or hypercholesterolemia. Their main characteristic is the almost systematic presence of calcifications due to calcium deposits within the arterial wall and antroluminal thrombi or blood clots attached to the inner wall. They often occur within a broader atheromatous disease, with simultaneous involvement of the coronary arteries in 60% of cases, lower limb arteries in 30%, or carotid arteries in 10%. Inflammatory aneurysms representing 5 to 10% of cases. These aneurysms have an inflammatory origin linked to systemic diseases such as Takayasu's arteritis, Horton's disease, or giant cell arteritis, and Behçet's disease. These pathologies cause chronic inflammation of the arterial walls, thereby promoting their weakening and dilation. Infectious aneurysms, often saccular or pouch-shaped. These aneurysms result from various mechanisms. It can be linked to a superinfection of a pre-existing aneurysm or rupture of the wall following necrosis. Septicemia, such as a mycotic aneurysm, which may complicate a bacterial endocarditis, or due to contiguous spread, where a localized infection around the aorta develops, often in immunocompromised patients. The most frequently involved microorganisms are Salmonella, Staphylococcus, syphilis, and Escherichia coli. Dystrophic aneurysms are often associated with hereditary disorders such as Marfan syndrome or Ehlers-Danlos syndrome, which affect connective tissue structure. They are typically located in the ascending aorta and are characterized by the absence of anteroluminal thrombus. There is a high risk of dissection during surgical clamping due to the extreme fragility of the arterial walls. Finally, some other causes. Post-traumatic, which are false aneurysms often related to penetrating injuries and postoperative occur as complications, sometimes due to leaks or failures of implanted aortic prostheses. An abdominal aortic aneurysm, if not treated, can lead to various complications. 1. The rupture. This is the most serious and most frequent complication of abdominal aortic aneurysms. The risk increases proportionally with the aneurysm's diameter. Even with emergency surgical intervention, the mortality rate is 75%. Retroperitoneal rupture is the most frequent form in 90% of cases, characterized by intense pain accompanied by collapse, which is a sudden drop in blood pressure, a deep pulsatile mass and reflex ileus due to the cessation of intestinal movements. The anteroperitoneal rupture causes a sudden hemorrhagic shock, often associated with hemiperitoneum or a bleeding into the peritoneal cavity, which is usually fatal. The duodenal rupture, also called aortoduodenal fistula, in this case an abnormal connection, fistula, forms between the aorta and the duodenum, leading to severe lower gastrointestinal hemorrhage and septicemia. The rupture into the inferior vena cava or iliac veins creates an arteriovenous fistula, which may manifest as acute high-output heart failure resulting from overload of the right heart, pulmonary embolism due to the passage of clots into the venous circulation. Aneurysms can also lead to the formation of clots or thrombi that detach and migrate through the bloodstream, causing embolization in the lower limbs, which can result in ischemia, insufficient blood supply to tissues, or cholesterol emboli, which are small deposits that block capillaries. Total thrombosis of the aorta, a very rare but critical situation in which both lower limbs are deprived of blood, leading to acute bilateral ischemia. Another complication, the compression of adjacent organs. An aneurysm can enlarge to the point of compressing nearby structures. The compression of the duodenum may cause pyloric stenosis, a narrowing of the stomach outlet, leading to vomiting and digestive difficulties. The compression of the urinary system can lead to hydronephrosis, a swelling of the kidney caused by urinary obstruction, more common on the left side due to anatomical proximity. The compression of nerve roots may cause radiculalgia, radiating pain in the legs, and the compression of the inferior vena cava may cause edema of the lower limbs, or even iliofemoral thrombosis, a severe blockage of the major veins of the lower limbs. Finally, infection and dissection. Although rare, aneurysms can become infected, leading to serious complications such as the spread of infection throughout the body.